talk will be presented by Dr. Matti Aapro from Switzerland. Dr. Aapro is Executive Director of International Society of Geriatric Oncology and President of a multinational association of supportive care in cancer. He will talk to us about the SIOG guidelines of management of breast cancer in elderly.
Good evening. I would first like to thank the organizers for having me once again here in Cairo. It's a pleasure to be again with you. We'll have several opportunities to interact today and also later during the panel of the cases and tomorrow. I was asked to talk about the geriatric oncology guidelines, and indeed it's one of the areas that many of you know I have tried to develop in the past few years with the collaboration of quite a few colleagues. And I would like to really thank Laura Biganzoli, who was the leader of the guidelines committee, where we joined forces between the International Society of Geriatric Oncology and the European Society of Mastology, EUSOMA, to produce guidelines which were then published in Lancet Oncology. There were quite a few colleagues who contributed to this work, and also we had a fantastic support from EUSOMA's Executive Director, Lorenzo Marotti, who was there once a week at least, if not more often, calling us, sending us emails and reminding us that we had deadlines and we had to write our paper in time because Lancet was waiting for it. As you know, this is not an easy field. It's a field in which there is a lot of opinion and little evidence. And all of that beholds also to a misunderstanding that continues to be discussed throughout the world, that cancer in the elderly person is more benign, and you well know this is not true. It is different. But when it has the same biological characteristics as in a younger patient, it is just as bad or even worse. As we recently published a review paper looking at triple negative in the elderly, which seems to be even worse than in the younger patients. We do know that there are many areas that we have to tackle, and in the few minutes that I've been allowed to have here, as all of my colleagues, I will only look at a few chosen chapters of these guidelines, of this consensus of SIOG. There are many areas that we could discuss, and I will just take a few of them. If you want to ask any questions later, I'll be around today and tomorrow, and I'll be more than happy to reply to your questions that I believe we will not have time in the plenary as we have other tasks and we have to finish before midnight at least. An area of major interest, of course, is what is the evidence that as we try in the younger patient to reduce the impact of our treatments, how can we do that safely in the younger patient, in the older patients? We actually do have, for a question that is under discussion for quite a few years now about the management of axilla, a couple of limited studies, but nevertheless very interesting studies that have looked at the elderly patients and have shown that indeed, as in the younger patients, within some specific situations, we can do only a limited exploration or even ignore completely the axillary dissection. Here's a paper that has looked at this question with a very long follow-up, because as we all know, we have to be very careful about conclusions in short-term follow-ups, also in the elderly, because may I remind you, an 80 years old, perfectly healthy lady has at least 10 years life expectancy. So we should not think that they are going to die within the next 2 or 3 years. This particular paper, for example, looked at the question of the axillary dissection versus no axillary dissection. And it is important to realize that in this study, they looked also at the question of whether or not radiation therapy was actually delivered to some of these patients. And it was only in the 34% of the patients that this was done. So this was not one of the control factors on top of anything that the surgeon had done. And in this particular study, there was no indication that the loss of information related to the axillary dissection was of any negative impact in the elderly patients. You all know the Z0011 trial and all the discussions that started when Giuliano published this data and then led to many guidelines changing the suggestion and stating that indeed in some settings, in patients with conservative surgery receiving radiation, there could be no axillary dissection. And these are the data, just to remind you about the Giuliano data, which confirms the data that we have for the elderly patients. In another study, which is not related to the elderly, but is a very important study, and this is the one that Viviana Galimberti first presented at the San Antonio meeting and then published in Lancet Oncology recently, we have further data showing that in the setting of patients that have no papillary adenopathy, and quite a few of these patients were above the traditional age cut of 65, there was no negative effect of patients having no axillary lymph node dissection. So what do the guidelines say? The guidelines say that yes, in clinically node-negative older patients, we can offer sentinel lymph node biopsy with completion of ALND only if there's definite evidence of metastasis. And in some settings, we might be able to omit this as we do in the younger patients. However, we have to realize that this is not true for every patient, and we have to take into account what is the biology of the disease itself, because this can be true for elderly patients with highly ER-positive disease. This might not be true for those who have triple-negative grade 3 disease, and where we could have quite a few false negatives. What about the radiation therapy? Some of you have been to the San Antonio meeting and know that we had a very important presentation there, and I'm happy to share the data from Ian Kunkler with you, as he sent me his slides right after his presentation. We had data from Hughes that was first presented at ASCO in 2010. That was one of several, this is not the only study, that pointed out to the fact that yes, maybe with a relatively short follow-up of patients, we could do without radiation therapy in patients with the characteristics you can see on the slide and who were receiving tamoxifen, because there was a little bit higher recurrence indeed in the patients not receiving radiation therapy, but at the end there was no difference in patient survival. These data were then updated in the Journal of Clinical Oncology just a few months ago, and with a much longer follow-up, now of 12.6 years, they continue to indicate that yes, there's no difference in terms of overall survival. However, there is a clear difference in terms of risk of local recurrence if you don't irradiate some of these patients. So when we had to put some recommendations out, and without this data, we wrote that yes, we believe that whole breast radiotherapy may not be systematically omitted. However, there could be some situations in which you might want to discuss with the patient that the risk of this particular patient of having a local relapse when she's receiving either tamoxifen or another appropriate hormonal treatment might be so low that she might want to forfeit at least classic radiation therapy. Maybe now with shorter-term radiation therapy or perioperative radiation therapy, the discussion could be somewhat different. So there was a discussion about this in the JCO, and while the group, the discussant applauded to this data, they still said we have to be careful that maybe there are some patients where it would not be wise, and they discuss about an age cutoff of 75, and especially about higher graded tumors. There was also a paper looking at some recommendations, and this was by Heppel and colleagues in the JCO. And this particular paper came to some discussion about the fact that we have to take into account the life expectancy of our patients, and once again look at the fact that the biology of the disease may be relevant. And now we have the PRIME data. And these are certainly going to be taken into account in the next generation of recommendations of SIOG and Uzoma. So Ian Conkler presented this study in patients above the age of 65, the majority being above the age of 70, who had a endocrine responsive disease, which was grade 1, grade 2. The grade 3s were excluded. And in their analysis, where they had a few grade 3s, they actually realized that the grade 3s were the ones that should never have been in the study. And these patients should not have had axillary lymph node involvement. So these are very good prognostic patients. And they were then randomized to whole breast irradiation with some different regimens or no whole breast irradiation. And these are the data as presented, a 5-year actuarial rate. So these are early data. We don't know what's going to happen at 10 years. Already show that there's an increased risk of local relapse in those patients not receiving adequate radiation therapy. This does not impact on survival, but it certainly does impact on patients' quality of life. Which patient will be happy to have a local recurrence? So we have to ask ourselves, where can we really limit the radiation therapy for these patients? And if we look more precisely at the data, we realize that if we look at the numbers, which are very small, of deaths, actually there are more deaths related to breast cancer in those not receiving radiation and compared to those receiving radiation. So the conclusions from my French colleagues who were at the San Antonio meeting and published a French-written summary of San Antonio during the meeting itself was actually that they believe that we should continue to consider radiation unless there is a major issue with the delivery of radiation for the particular patient. What about adjuvant treatment in the elderly women? We know that we have had for several years the seminal trial of Haimas and colleagues that has shown that indeed in elderly patients above the age of 65, quite a few of these patients being above the age of 75, the treatment with a standard anthracycline cyclophosphamide regimen or CMF was superior to the way capecitabine was used in this particular study. We also know that these data are very much related to the fact that the benefit was, as should have been expected, in patients who had estrogen receptor negative disease. We have since then also had further data from an observational cohort study that was done with the SEER data that has also shown that in these patients there is a benefit of chemotherapy in general. Many continue, for reasons which I personally do not understand, to say that in the elderly patient they would use CMF. By heaven's sake, forget it. CMF is more toxic in the elderly than AC, at least in the short term. This has once again been shown by CLGB 49907. We do have alternatives to anthracyclines in those very frequent elderly patients that have cardiac issues, where we do not want to see early or later cardiac problems with anthracyclines, even though we should admit that the French data with epirubicin are quite reassuring, contrary to anthracyclines of the doxorubicin variety. And we do know that TC is an alternative for the patient that can afford this type of treatment. We know that we can deliver taxane-related treatment in elderly patients. This comes from a fantastic analysis of Sybil Loyal with more than 4,500 patients above the age of 65, and there were relatively big numbers above the age of 70 that show that, yes, we can deliver. There are some more side effects, but these are not prohibiting the use of adequate taxane-related treatment for these elderly patients. So what is the suggestion of the SIOG Guideline Committee? That age is not the reason to decide whether or not chemotherapy should be given. This depends on the biology of the disease. That certainly AC-like regimen is preferred over CMF, and we continue to discuss that taxanes might be superior to AC in the younger patients, and why not in the older patients. I would like to conclude by discussing something that is not in the guidelines, it's only alluded to in a small paragraph. We all know that all of our patients that receive aromatase inhibitors in the adjuvant setting will have issues related to aromatase inhibitors with the bone integrity, leading to an increased rate of fractures and all the problems related to this increased rate of fractures. We have also known for years that we can check these patients prospectively and we can intervene before the loss of bone integrity becomes dramatic with several types of bisphosphonates. What has been a debate for several years, and I have had the pleasure to discuss this with you in past meetings of BGICC, is that we have had data showing that bisphosphonates do not only influence the bone integrity, but can also influence the outcome of the adjuvant treatment with aromatase inhibitors and other hormonal treatments. This was a debate because there have been, as it happens very often, contradictory trials. Some stating that yes, there was a clear benefit, others saying that they didn't see a benefit. So as usual, a meta-analysis was done and presented by Dr. Rob Coleman at the San Antonio meeting. And I'm sharing here the slides that Rob sent me. In terms of distant recurrence, patients who are in postmenopause, either natural postmenopause or induced postmenopause by an LHRH analog, do have a benefit with use of bisphosphonates along with anything else they're receiving in the adjuvant setting in terms of distant recurrence, of bone recurrence, but not of non-bone recurrence, which was indicated by some studies but is not seen in the meta-analysis. The data, as I said, is true for the postmenopausal patients, is not true for the premenopausal patients who are not put into menopause by an LHRH analog. But more importantly even, the meta-analysis confirms the first indications that came from Michael Gnan's study and then by subsequent studies, that this is actually translated into benefit in terms of breast cancer mortality. So my conclusion at this point in time is that we should really consider, with the data that has been shown to us by this meta-analysis, that in elderly patients who are very often already osteopenic, there should be no reason to withhold an every 6-month infusion of zoledronic acid or the use of clodronate, which are the two compounds which have clearly evidence in favor of them in the setting of adjuvant treatment for breast cancer. We have, of course, to take into account quite a few other factors in our elderly patients, and one of the most important factors are socioeconomic factors, which unfortunately are an issue throughout the world for elderly patients. And with this, I would like to invite you to come to the next SIOG meeting in Lisbon, Portugal at the end of the year. Thank you very much for your attention.
Thank you very much, Dr. Aapro. Do we have any questions? Okay. Thank you very much.
Thanks.